If you've ever seen the cult classic movie Soylent Green, you'll know exactly what this next session is all about. A dystopian future with too many people, too little space, and not enough food to go around. The swell of health problems that would come with this kind of population boom would see an international crisis, nothing like anything that we've seen before. Is health tech prepared for this kind of future? And what about the present? What about health tech right now in the present? Here to discuss everything from epidemics to ethics, please welcome in conversation with the Telegraph's Paul Nuki, Chief Technology Officer of Oscar Health, Alan Warren, Chief Data Officer with the US Department of Health, Mona Siddiqui, and Symantec Lead Researcher, Aleatha Parker-Woods.
Hey, thank you very much. So the population growing to, it says here 10 billion by the end of the century. It's on the UN estimate, it's actually about 11.2. And then probably to most people's relief, it flattens off after that, so we don't need to worry about it going up forever. But it nevertheless, 10, 11 billion people presents quite a challenge and perhaps the greatest big data opportunity for healthcare over the next, well, how long is it? 80 years. So we want to talk a little bit, first of all, about how much of a problem is it as a data processing problem, or a data problem at all? Can our computers keep up with it?
I think from a storage problem, we don't have any issues. I think the biggest file systems today are already handling 10 billion records and beyond, but I think there's some really interesting challenges, especially around real-time health processing, like Alan's company does. So. Yeah,
so from our computers can handle it, can't they? I mean, it could be 10 times that number, and our computers are not going to have an issue handling the data itself. But Alan, you run a business which isn't just about data, it's about people, right?
Yeah, and I think that's the key to the problem for us. Compute systems with cloud computing today, we can scale these systems. You look at companies like Google, they think about 1 billion users, active users, as being sort of a minimum bar for you being important inside the company. So computing systems today, storage systems and the like, they can handle this kind of scale. But we're in the health insurance business, and it's a really interesting and powerful mashup of these machines and these systems and software and all of this data with the people that are wrapped around it and providing care and connecting with our members and the like. And the people part, trying to scale that to 10 billion, I don't know how that's going to take a while to get there. The machines we can scale. The people part of the processes is going to be a challenge.
So, and those people are always going to be needed, right? Your advisors, your medics, is that right? Or do you see them slowly being made redundant as the technology gets smarter and the century progresses?
Well, it's bent over into a lot of the debate around AI today. People talk about how you'll have some AI that'll answer the phone and will help diagnose all of your problems and get you to the right. We have found that our members want to connect with people. We've got tremendous digital offerings and apps and things you can use, all self-service, all on your own, if that fits what you're interested in. But large swaths of the population, they just want to talk to somebody and know there's a person on the other end of the phone. And you have to be able to handle all of these channels of communications.
And I guess that's particularly true when people are ill, right?
Yes.
Yeah. Okay. Mona, for you, the US government, what the scale of it all, does that worry you in itself?
So I think we have to talk about why the data is important, and really, as a federal government or as any responsible healthcare system, as we're moving into a more value-based care system, it's really, the underpinning of that is really a data-driven system. And so being able to target the right services for the right people at the right time, that is, I think, what the ultimate purpose should be. What are the problems that we're trying to address? How does the data actually help us address those? At the end of the day, we talk a lot about, even now, about a physician shortage. I don't think we have a physician shortage problem, or at least not as big as the one that we talk about. I think it's really managing our resources appropriately and being able to define who needs a particular level of care. I think companies like Oscar and others are trying to do this. I think more and more healthcare systems are moving in that direction in the US. Ultimately, I think that is really the power of data, to be able to provide the care, the right care at the right time.
Okay. So we should maybe talk a bit about equality and healthcare. So 11 billion people in the world. Health for some becoming almost miraculous, probably, compared to what we have now. Really detailed personal interventions in small corners, I suspect, small rich corners of rich nations. But then there are still, it's less than 10% now, but it's still 9% of people in the world who live in extreme poverty. Some of those won't yet have seen a phone. And so how do we manage that equality issue going forward? I don't know if you want to talk about that first, Aleatha?
Sure. I mean, I think one of the things that's amazing about this data-driven revolution is that it does in some ways bring a little more equality to it. I think that we know who needs what much more quickly. We can be more targeted about our interventions, and I think that benefits everybody, and I think that's amazing. But we do need to be very realistic about things like data portability. There are a lot of people in the developing world who will either they just have a smartphone or they have no phone at all. They have no network connectivity. And so how do we deal with just managing health records for these people and being able to move them around? I think it's a huge challenge.
Yeah. So it's an important point, I think, that the data in itself will drive healthcare for billions. But nevertheless, I think in the States, Mona, you look down, you already see some real disparities happening. It's possible, I think, to see homelessness as a problem, in part anyway, which is about a lack of access to mental health facilities. So maybe you want to talk a little bit around that, and I think you've got some observations about how the opioid crisis breaks down in terms of regions.
Well, I'll put on my clinical hat for a minute, and I trained in Baltimore. I don't know if anyone is familiar here with Baltimore and Maryland at the Johns Hopkins School of Medicine, and the zip code that Hopkins sits in has and I forget how many other zip codes around that area, but there's essentially a 20-year lower life expectancy for Black men compared to the surrounding zip codes. Now, this is happening in the US. And as the chief data officer, I will say that this is not a data problem. This is and not every problem is a data problem. This is a problem of how we're providing social services and how that links to the healthcare system. The two systems traditionally have been so distinct. How do we actually pay for the things that we value that have ultimately healthcare outcomes? So we can look at all of those systems in complete isolation and say that housing is a separate department and employment is a separate department, but ultimately all of that leads to incredibly poor health outcomes for those individuals, which is unacceptable in a developed country, that is the status for a minority population in the US. And so thinking increasingly about how does the healthcare system start to pay for value, how are we paying for those upstream social determinants of health that we talk about a great deal, but that our healthcare system is fundamentally not designed to address. And who are the right partners at the table? And it can't just be the healthcare system. You have to bring in many other players to the table.
Yeah. So, Alan, I'm going to play the devil's advocate, right? You're the insurance guy. Mm-hmm. You're the guy who as all this data comes in, you're going to say, well, his genetics don't look quite right, I'm not going to insure him. Mm-hmm. How do you come back at questions like that? And how do you see insurance helping in the longer term?
I mean, stepping back and coming back to the accessibility question, this as Mona says, is as much a problem in the United States as it is in the rest of the world. And it's not generally so much a problem of finding a doctor. We know that there are shortages in that arena, but it's how do you get to the right level of care and how do you pay for it, if you're particularly in high cost areas of the world. And that's one where the US actually may be at a disadvantage because of the extreme costs in our nation. And one of our core premises is that we have to be able to provide affordable insurance for everybody. And the only way to do that is look at an entire risk population and spread the risk out and the costs out across the entire population. And these efforts around pre-existing conditions are really geared towards isolating certain pockets and say, no, those are going to be really expensive because they have something known going on, and we're going to try and reduce the costs for everyone else a little bit. We think that in order to make it accessible for everyone, you need to be able to spread those across. So we're much more in favor of uniform coverage for everybody without any kind of pre-existing coverage, gates and fences on it.
Okay. So we've got some questions coming in here. So someone's saying, isn't it better to think about how growing technology is actually killing people? Ex-GMO. I'm not sure I understand that. Do you? I don't know the person who put that up wants to talk about it, but and then there's a question here about, is a challenge the amount of people or the aging of the population? So who wants to talk a little bit about that? It's an interesting question. Mona, you good on aging?
Yeah, so, I think we have to, as a society, we have some cutoffs for, when people should retire and when certain benefits kick in. I think we're going to have to start to look at some of those benchmarks over the long run. We can't have an entire segment of the population aging out of the workforce. How do we start to bring some of those individuals back into the workforce? I think that's an important topic, both from the government side, but I think from corporations as well. Again, I don't think it's a matter of the aging population. From a medical perspective, it's how do you target the right care for the right people at the right time? And I think there has to be an increasing emphasis on preventative care, which we haven't focused on nearly as much as a healthcare system. There is so much focus on medications and treatment. How do we focus on disease prevention? And I think that has implications not just for the aging population, but really for the way in which we talk about the medical profession as a whole as well. Yeah.
So I guess that's quite a north question anyway. I mean, the population is aging in the north, but it's not going to age forever. By the end of the century, it'll be evening out a bit. And in the south, it's going the other way. So Africa is going to be hugely young. Aleatha, you're expert in security. What does this huge amount of health data mean in security terms? Is it something that we need to worry about?
This is actually something that I think about and worry about a lot. I'm very concerned with data privacy. I think in the developing world, in the EU and the US, we feel reasonably comfortable with the privacy guarantees that we've got, but I worry about people taking advantage of the developing world as they start to come online, start collecting these health records, monetizing them, misusing them for malicious advertising. So I think it's really important as we bring people into the global healthcare system to have strong privacy guarantees, strong privacy technologies around their health data. Technologies like differential privacy, homomorphic encryption, I think these have the power to protect a lot of people as they come online.
So we were talking earlier offline about the sort of motives that hackers have or could have for taking health data. And I wondered if you wanted to say something a little bit about your thinking around that.
Yeah, absolutely. Hacking has changed over the last couple decades from a sort of intellectual curiosity pursuit to a really big business. There is an entire market in people's data, an underground market. And so healthcare data, just like any other kind of data, if you can monetize it, it has value. If you can use it for targeting spam, if you can use it for any sort of blackmail. So yeah, that's a huge concern.
And I guess those are things that we don't need to just worry about at scale, but for individual companies and compliance officers, that's going to become a bigger and bigger issue, I guess. Because as we've seen in the UK and in the States, just the publicity damage alone from a successful hack has an impact. Is that something you guys look at in the at Oscar?
It's absolutely central to what we think about when we're building systems, architecting them, how we think about connections to partners, who we can partner with, what kind of companies we can actually work with when we need to store data on their systems or send things through their networks. It's enormously complex, and there are really strong competing tensions here. We really want to make it easy to pull all of the relevant information together around individuals. But the more easy you make that, the more channels you open up for potential vectors for attackers to come in or for data to get leaked out. And so how you balance that and manage controls around that information once it's been pulled together so that the patient, the consumer actually knows and can control who can get at the information for what kinds of purposes. It's enormously complex.
Yeah, and it's a problem that it sort of drives itself, because as health data becomes more and more valuable, there's more and more incentive to get in and pinch it, right?
Yes, absolutely.
Okay. So shifting the subject a little bit is that most of these 10, 11 billion people who will be in the world by the end of the century, they're not going to be in this bit of the world. They're not going to be in America, they're not going to be in Europe. Most people are going to be in China, Asia, Africa, India, of course. And that, I think, presents some challenges on the data front. It may not be the wealthy North that has got this treasure trove of data, and it could be that we're no longer leading in this anymore, right?
It's entirely possible that the developing world will leapfrog us as they come online. They've got a huge diverse population to draw from, and weak data protections again, so you can imagine that may actually lead to a burst of research that might be done unethically with poor controls, but they can learn a lot very quickly.
Mona.
Yeah, I will say that in some of these countries, the data infrastructure that's getting built is primarily driven by either security or surveillance concerns, and not from providing social good. And I don't think that healthcare has been at the forefront of those conversations. I think the US also has an inbuilt sort of advantage in that we have an incredibly diverse population. And so to be able to study over time the development and progression of particular conditions and be able to tie that to a very genetically diverse pool, I think that is an incredible advantage. And as I mentioned earlier, our project at NIH, which is looking at collecting data on 1 million lives, both healthcare, traditional healthcare data and non-traditional sources, and bringing in genetic information, is attempting to do that and attempting to collect information on a very diverse population and trying to enroll people from backgrounds that wouldn't necessarily enroll in trials traditionally. So I do think that there is that built-in advantage, and I think that healthcare is at the forefront of some of the things that we're trying to do from a big data perspective.
Alan, do you worry that other bits of the world may get ahead of you, that Chinese insurance companies may know a bit more about us than American ones or British ones, ultimately?
I think there's probably more concern about that at the clinical side. They can do a lot more with clinical data. On the infrastructure side, I'm less worried, and I'm actually finding a strong interest in taking technology as being built locally and using that more broadly. The problem is that while the technology and the data itself can be very broad-based and generally accessible, when you get down to care, that becomes very local. You have to get to the particular doctor in the particular village or town or city anywhere around the world, and all of those connections and access points are distinct and varied, and being able to scale that part of the problem out is what really gives me pause in how
so that's about the logistics of care, isn't it?
Yes.
And universal access.
Yeah.
Right. So yeah, to wrap up then, by the end of the century, are we going to be pleased with this data revolution? Is it going to unite the world? Is it going to bring great insight, or is it going to be more sinister? Well, just give me a view, each of you, positive or negative.
I think that's really on us. I think we have to make good decisions that are going to make it a positive outcome. We need to have good privacy controls. We need to do as much ethical health research as we can. But, I'm hopeful that if we make the right choices, it'll be a good outcome.
Hopeful but careful.
Always.
That's good for a security person. Mona?
As an eternal optimist, I will agree that I think over time, as we address some of the concerns that really haven't been addressed explicitly, whether those are security or privacy and the responsible use of data, I think that we will ultimately be able to provide much needed services to individuals who even currently are not getting those. And so that is really my ultimate hope for the potential of big data.
And Alan?
Yeah, my general feeling is that the technology and even clinical expertise are going to be huge advances over the next several decades. And those are going to be available very locally. There are going to be centers like Hopkins or Cleveland Clinic that we partnered with. There will be centers like that will be well on the forefront. They're going to be able to do amazing things. How we carry that understanding to the middle of Africa, to China, to India, and other parts of the world that don't have those facilities and capabilities locally, that's our big sort of global challenge here, I think.
Okay. So I think it's fair to say we've got a pretty optimistic panel. I would be optimistic too. I think the history of the world is one of gradual progress, but definite progress. So thank you very much for listening. Thank you.
Thank you.
Thank you very much.